Hello, everyone. Thank you for joining today. I have Ebony Fisher here. She is going to be our speaker today on our community learning series, Health Disparities in Communities. Ebony has over 20 years of a nursing experience. She's been in nursing academics for 15 of those years. Her background in nursing is medical, surgical, behavioral health, and telemetry nursing. We will wait and save your questions for the Q&A at the end of the session. So if you have any questions, please throw it in the Q&A area and we will get to it after her talk. Ebony, I'm going to turn the time over to you.
Good afternoon, everyone. Again, my name is Ebony Fisher, and I will be discussing the health disparities in communities. I will be sharing my screen right now so we can get started. And so as we look at health disparities in communities, one thing is we need to look at to be able to further understand health disparities that occur in all of our communities is we need to be able to understand the social determinants of health, okay? So the social determinants of health are the conditions and the environments where people are born, where they live, where they learn, where they work, where they play, where they worship, and age. That's how they affect the wide range of health that they experience, their functioning and the quality of life outcomes and risks. So in looking at the social determinants, we need to understand that our health is determined in large in part by our economic stability, education access and quality, healthcare access and quality, neighborhood and built communities, and also the social and the community context in which we live too. So Healthy People 2030 is a government initiative to look at some of the social determinants of health. In the 70s, Surgeon General Julius Richmond did a report on the social determinants of health, and so they were able to subscribe like certain data sets. And so every decade they have looked at the data when it comes to looking at social determinants of health, and they have updated and revised it. We're currently in the Healthy People 2030 data set right now. And what this focuses on is health equality, social determinants of health, and also health literacy with the new focus on well-being. And so again, when we look at social determinants of health, there are many organizations out there, including the World Health Organization that looks at social determinants of health. But for this presentation, we're going to focus on our own government, the United States of America, what they have defined as the social determinants of health, and its 5 domains. So inequalities. Social determinants really affect inequalities. And so health equity is when there are people are able to have full health potential, and no one is disadvantaged, and no one comes from a disadvantaged background. Unfortunately, that's not true in our healthcare system across the world. There are many different disadvantages that are out there. And so when we talk about inequities, we have to look at the unequal distribution of access to healthcare, quality healthcare for all. And so some of the examples that can determine inequities are how a person develops in their early childhood. We all know that everybody doesn't come from the same family, nor from the same household. It would be nice if we were all born with the silver spoon, or we were able to, get the health care that we needed in the beginning to prevent certain childhood diseases or deformities or those types of things. If we all were able to have the same types of education, some of us are not privileged to grow up in areas where there is good quality education. Some of our parents are not able to afford to live in areas where good education exists. And so we do know that education is the key in order to have better health outcomes. Also being able to get a job. So we talked about social economics is being one of those 5 domains. So getting a job, everybody doesn't have the same opportunities to get a quality job. Could they get a job? Yes. Will it pay the money that they need in order to be able to access healthcare? Maybe, maybe not. Will that job include health insurance? Maybe not. So that is an inequality too as well. What kind of work the person does? That could be inequality too. Maybe they do hard labor, those types of things, which puts them at risk for having back problems and those types of things. We have found out the more educated you are, the less hard labor you're going to do. Having food, being able to have food security. Food is part of nutrition. If you don't have good nutrition, then you're going to have a health inequality. Your health is not going to be good because you lack the nutrition that's needed to have good health. Also, having access to health services and the quality of those services. We know people that are in rural areas, they don't have access to healthcare due to the transportation issues, due to not having good quality healthcare providers. There are initiatives all across the country in trying to get healthcare providers, from nurse practitioners, physicians, physician's assistants, to come to these rural areas, but no one wants to come there because the money is not there. So the government is trying to offer, scholarships and loans paid off and those types of things, so those people who live in those areas can have access. Living conditions. Living conditions is another inequity that people face. Some people don't have the luxury of having running water. They don't have the luxury of having electricity and light. And so if you don't have running water, if you have a wound care issue, then you're not going to be able to allow your wounds to heal properly because of cleanliness. Also, people, the money that they earn. So again, your individual income, household incomes, all of those are going to play an effect in whether you can be able to attain the medications that you need that your doctors prescribes. Social norms and attitudes. So again, discrimination, racism, biases, distrust with the federal government, state and local government. We saw that with COVID-19. A lot of people did not believe that getting COVID vaccines would cure or help to control the COVID rates. And we saw a lot of people of color who didn't trust the federal government. They thought that the federal government was trying to kill them off. And so it would be less of their race there. I got to experience a lot of that when I was giving COVID shots during the COVID-19, and, people talking about this, like, can I ask you a question because you're a person of color or because you're Black? Is the government trying to kill us? And I would smile at them and say, I took the vaccine and, I think I'm pretty educated about it. And so, those are things, the social norms and the conversations that these people have and that they actually believe. And then the federal government has done things in the past, like the Tuskegee experiment with syphilis, where they took all these African American men and they gave them syphilis and did research on those. And so that has been passed down from generation to generation. And that has happened in other racial groups like Native Americans and other types of people where they have done experimentation. So those things have been passed on from generation to generation, and there is a distrust in the federal government. Also, the areas in which we live. A lot of places have segregation, neighborhood segregation, where the Blacks live on one side of town, the Hispanics live on another side of town, Asians live on another side of town, and that can affect healthcare. There may not be good access for those neighborhoods when it comes to healthcare access. Social support. We need to look at social support. What social support do people have? Do people feel like they're actually have the social support that they need in order to access healthcare in their area? Language and literacy. If you don't speak the language, English language, a lot of times our people who speak other languages and English is not their first language, they have a disadvantage than other people who do speak English because they feel like they don't understand. So Again, hospitals have to make sure that there are interpreter services there. Incarceration. There are many numerous research articles about inmates do not get the healthcare access that they need. People have come out and talked about that, just because they were in prison, that they were allowed to suffer longer than folks who were, a part of the regular population. And culture, our beliefs in where we come from, in those neighborhoods, those backgrounds, our socioeconomic status, all play a part in how we determine our access to healthcare. And in the mass media, the media does not sometimes do a wonderful job in painting accurate pictures for people when it comes to healthcare access. We witnessed that with COVID-19, that a lot of times we got inaccurate information. It was not based on what the CDC said or what the federal government and organizations who were actually putting out the information out there. And the media misinterpreted, or they were on their own political agenda. So those are just some examples of how inequalities are determined throughout our country. And so when we talk about the WHO looks at, it's a organization, and we learned a lot about the WHO during COVID-19, but they also have put out what the social determinants are. And so in 2018, they said social inequalities are unfair and they are completely avoidable. We can avoid a lot of this health inequalities that are out there if we educate ourselves, and if we try to make some changes, and if socioeconomic is not just given to the rich or the middle class, but it is shared equitable among all. And then we also do need to understand that there are differences in our populations, within groups in our populations, age groups, race, where we live, whether we live in an urban area or whether we live in rural area. There are differences, and we need to acknowledge those differences so we can overcome the inequities that are experienced there. And then also inequities can be reduced by the right mix of government policies. So we need to make sure that we have the right policies out there that are aiming to prevent those inequities that can be avoided in healthcare as well. So when we talk about the domains, those 5 domains, we do know that economic stability is one of Healthy People 2030's initiatives. And so that domain their goal is to help people to earn steady income that allows them to meet their health needs. And so again, in the US, 1 in 10 people live in poverty. That is over 10% of our country live in poverty. And we know that many people just cannot afford the day-to-day things that they need. That they can't afford food, they can't afford healthcare, and they afford housing. Many times I tell my students in my fundamentals class here at Joyce University that if you had to make a decision between buying apples and buying cookies from your family, what would you do if you didn't have the money? And so we begin to break that down. We begin to talk about, what does that actually mean? Well, a pack of cookies you can buy at your local grocery store for $3 or under. Usually they have a sale on some type of cookies. However, when we go to purchase apples for our family, 3 apples is like $3.50. So if you had a family of 6 and you were poor and you had to have a snack for your kids after school, most people are going to pick the cookies, which are not considered healthy, because they don't have the income or the resources to be able to give all their children an apple with $3.50. A whole bag of cookies can last the whole week if you give 2 cookies out to each child. So they begin to think about it, and they say, oh, you're right. I never thought about that, but fruit is high and fruit is very expensive. I tell my children that, fruit is expensive and you should be thankful that we have that. So my daughter always jokes and said, well, Mommy, we should grow our own fruit. And she's right that if I had the means and the ability to, I would, but everybody does not have that ability and means. And so the things that some of us take for granted, other people, children don't get apples and oranges and those types of things. So with Healthy People 2030, again, they're focusing on helping people to achieve economic stability. And if that's, some organizations and some companies and people are trying to start, non-for-profits where there are community gardens in the area. And that may be something that a lot of people, hospitals or organizations in your area can think of when we talk about economic stability. So people can have food security and they can have employment because they can help grow those gardens. I know a place in Dallas, Texas, they have a community garden, but they also take that community garden and what grows in that community garden, and they actually hire people to pick that community garden and they use it in a restaurant and they serve low-cost meals to the community. So wouldn't that be a beautiful way to encourage economics? So again, people with less steady employment are less likely to live with steady employment are less likely to live in poverty and more likely to be healthy and to make better food choices and to have better housing stability and to live in better housing. Another domain of Healthy People 2030 is education, access, and quality. The goal to Healthy People 2030 is for educational opportunities for children, for them and adolescents to have better opportunities. So with Healthy People 2030, we recognize that education is key to preventing these health inequalities that are experienced by the population, the United States population. Again, people with higher levels of education are more likely to be healthier and live longer. The research has proven that time and time again. The more educated you are, the less likely you are to die early and to live a healthier life. So Healthy People 2030 is focusing on these high quality educational opportunities for children and adolescents because we want them to do well in school. They should do well in school and they should be able to break those generational curses that their parents had. And a lot of times they do not live later. So I don't know if you guys have ever seen the movie The Coal Miner's Daughter with Sissy Spade. That's like one of my favorite movies. But in that movie, her parents were actually young people. But if you looked at them, they were in their 30s and 40s, but because they lived in a poor society in Kentucky in the coal mines, and her dad did hard labor, he looked older than 30 or 40. He looked older than 40 years old. To me, as a child, he looked like he was in his 70s. And I remember my mama saying, you know what, Ebony, I'm from Southeast Missouri. She said, Ebony, that man works hard. He works 16 hours a day, and that's why he looked older. And, he didn't have education. So that's why I want you guys to have education, because I want you guys to have a better life than me and your father. So thankfully, all four of us went to college, and we all have good jobs, and we didn't have to do hard labor, and was able to make a better life. And so if you know better, you do better. And so that's what Healthy People 2030 is saying, is that if you have better education and you're not like the coal miner's daughter, they only went to the second and third grade, then you're going to do better and you're going to live a better life for your children. And then also with language literacy, we found that people who have language and literacy, and if they speak different languages, if they come to this country speaking Spanish or Polish or wherever they're from, then they tend to not understand their healthcare providers. So we are to offer classes that help them to be able to understand the English language, then they're going to have better health outcomes than the person who does not understand the English language. So in domain 3, health and access and quality. So again, Having access to health is super important too. The goal of Healthy People 2030 is to increase access to comprehensive and high quality health care services for all. Okay, and we talked about the rural areas, people who live in urban areas sometimes do not have access to healthcare as other places. So I live in St. Louis metropolitan area, and sometimes I give my students the example of, I live in a community in the Creve Court area in St. Louis, and so that is an affluent area, and I'm privileged to live there. But however, if you go to North City, St. Louis, those people do not have like urgent cares on every corner. And in Creve Court, we have urgent cares on every corner. We have doctors in every corner because everybody wants to, practice there because there's money there. However, if you go to North St. Louis, those people have low incomes, and so they don't have access to healthcare services. So guess where they go? They go to the emergency room. And we all know that if you go to the emergency room, it is not intended for acute services where colds or urinary tract infections, those should be seen by our physicians or urgent care areas and not utilized for emergency rooms. However, if you don't know any better, you won't do any better. And so again, that does have something to do with healthcare access. And then I have the opportunity to live in a small community. And this is why this is so important to me, is because in small communities, sometimes we don't have access to specialists because nobody wants to practice there. I remember when I first graduated from nursing school, we had an OB doctor, and there was only 2 OB doctors for miles around. I would say 60 miles around. So everybody had their baby at this one hospital. Unfortunately, that doctor got tired all the time, and a lot of times he would oversleep. And so the nurses would have to end up delivering the babies. Is that a good health outcomes for people? No, that's not, because that's beyond our scope of practice. But because he was tired, he was trying to get out of bed, he couldn't sometimes get there. And so again, specialists like cancer doctors, they're not there. 20 years ago, people had to go all the way to St. Louis, which is two and a half hours away, to have access to good cancer care doctors. Until recently, they opened up a cancer care place in Cape Girardeau, which is still 45 minutes away. So finding people like psychiatrists, that's hard. With a organization in the Boo Hill, where is in Southeast Missouri, where I'm from, they're looking for psychiatrists and mental health nurse practitioners. There are none to be found. And so a lot of times when they do find them, they don't stay long. They just get their loans paid and they leave. And so those people have no access to psychiatrists and therapists because they all want to practice in urban areas where the incomes are higher for them, and it's better for them overall. They have more access to entertainment and those types of things, and housing, and that's where everybody wants to stay. So again, we do understand that health access can be affected by the areas in which we live and the communities that we stay. And also we need to look at, 1 in 10 people in the United States do not have health insurance, okay? Not having access to health insurance, again, those people are going to frequent their emergency rooms, and they're going to get all of their care through the emergency room. And we know that that's not where the emergency rooms are not intended for that. And so again, we need to make people, again, it goes back to economic stability and making sure that they have the right jobs and the right healthcare and coverages to be able to access healthcare so they can get preventative care for things like chronic diseases and getting healthcare education and immunizations and things like that the emergency room does not provide. So again, primary care services are lacking in those areas because, again, if you do not have access to healthcare, you will utilize the emergency room or no care at all. The next domain is neighborhoods and built environments. So again, access to Healthy People 2030, one of their goals is to create neighborhoods and environments that promote health and safety. And so again, people who live in neighborhoods, neighborhoods can majorly affect their health care and their well-being. So again, where we are born, where we live, where we learn, where we play, where we work, they all influence our health care. And so people sometimes live in areas where there is a high occurrence of violence. And so like in St. Louis, I can use them for example. In North City, they see violence every day. You'll see on the news that with our per capita, and our population, St. Louis has a high crime rates in those areas, and it comes from all of those areas where those people are uneducated, they're poor, they lack access to health care, and sometimes are considered violent because of the things that they go through. And those neighborhoods that have those high violence, they usually have unsafe air and water. They have health and safety risks like lead in their paint. Those kids are the children of those people who live in those older homes. They were built before the 1970s, and we do know that paint had lead in those paints. And so we see those kids come into the emergency room where they eating the chip paints off the wall. So again, that is going to play an effect on there. We also know that people of color live in those areas, and they live in low income areas, and those low income areas have those risks. And so again, we have to look at those environmental conditions, the quality of housing that's in those areas, because they are going to determine the social conditions that are in those particular areas. And so the last domain that the Healthy People 2030 is the social and the community context. And with the goal of Healthy People 2030 is they want to increase the social and the community supports that are out there. And so again, people relationships and their interactions with families, friends, co-workers, their communities can have a major impact on their health and their well-being. So again, we want to make sure that people are not living in unsafe communities, that there are no discrimination or racial biases that are occurring, and that they can be able to afford the things that they need. And so we know if they can't, then this has a severe negative impact on their health and safety throughout their life. And so again, we don't want these people living in areas where violence is occurring, because again, you have the need to defend yourself and have to do things that criminal activities that you shouldn't be participating in order to feel like you have to survive, in order to feel like you have to have food and clothing and shelter. And so if you talk to a lot of incarcerated people, which I've had the ability to do because I've done forensic nursing, and you ask them, why did you do the crime you did? And they say, well, initially I started because, my mom, was working 3 jobs and we didn't have, food or shelter, or we were homeless. And so I started selling drugs, or, I started hanging out with the neighborhood dope dealer or the neighborhood pimp. And that led to my incarceration here. So again, their neighborhoods, the social context in which they came from, the communities in which they came from, it really influenced their health. It influenced all types of things. I remember one inmate telling me, you know what, I made a lot of mistakes. I was bright in school. I did everything all the way up to the end, and I was being bullied in school, and so I ended up shooting someone because I kept complaining about it and no one would listen. So that was very and then he didn't have good representation. So again, that affected him being in incarceration and not having the social supports that he needed in order to, for that bullying not to occur, because he wasn't in a good school and they didn't have the security that they needed to help him and to protect him. So again, all of those domains, they all kind of intermix and mingle with each other. If you have one area of concern, then you're probably going to have another area of concern on those 5 domains that Healthy People 2030 tells us about social determinants of health. So let's talk about what can we do. We know what social determinants are. So what can we do as nurses and the community in order to prevent these social determinants? Because we do know that they are avoidable. So when we talk about social determinants of health, we're not new to this. This has happened for a long time. And one of our pioneers in nurses is Miss Lillian Wall. So Lillian Wall is known for the Henry Street settlement. She was really dedicated to the immigrants who were on the Lower East Side of New York. And she had a special mission when it came to immigrant health. And so she was the founder of what we call now public health nursing. So she established that Henry Street settlement to address her concerns about the poor and immigrant communities, because we know people who live in communities that are poor are more likely to have healthcare problems. And Miss Wall knew that too. And so she was a visionary, and she visioned that people, just because you had social determinants of health, then it shouldn't affect your health outcomes, and you shouldn't have adverse health. And so again, she started the public health nursing, and she really wanted to prevent diseases that these immigrants were experiencing. We know that in Europe, we had the bubonic plague in poor areas, and a lot of people died that lived in poor areas. So this has been happening all across history. But thank goodness for Miss Wall, who saw this, and she had a deep conviction when it came to poor people and immigrants to help them. And so nursing in general has a social mission, and to look at the inequalities of all people across the board, okay? And so again, Miss Wall started this in the 1800s, and this has just been continuing throughout. And so we need to look at the people who are in these areas, these poor areas who don't have healthcare access, and we need to make it our social mission, and we should also be looking at social justice for all who have inequalities, because we all should have equal health across the board. Now you say, Ebony, how can we get this done? Well, we need to look at our profession, our mission for the profession. And I liked what Moreland said. She said social mission is the contribution of the school in its missions, its programs, and the performance of its graduates, its faculty, and leadership to enhance health equity and to address the health disparities of society in which it exists. So she just didn't lay it on just Miss Lillian Wall and public health nurses. She said it goes to everybody. It goes to graduates of nursing school, the faculty of nursing school, leadership everywhere, to enhance health equity among us all. And so again, the future of nursing, the 2020 to 2030 report, charting a path to achieve health equity, states that all nurses at all levels, no matter what setting in which they work, have a duty and a responsibility to work with other healthcare professionals and sectors to address social determinants of health and to achieve health equity. Okay, this is everybody's responsibility. And so when we look at our responsibility and our commitment of the nursing profession to provide safe and quality care for all individuals, families, communities, and populations, this is something that we should put at our high goal in every one of our lives. Our professional goals is to make sure everyone receives good care and equitable care. All right, and so when we look at how do we do this as nurses, we're going to look at the nursing plan. So the good old-fashioned nursing plan. So we should look at our assessment. How do we assess people who are at risk for inequities and healthcare disparities in our communities? Well, there is different assessment tools that are out there. And so, unfortunately, there is no standard assessment tool out there. But however, employers and hospitals and community clinics and public health departments, we can utilize some of these tools and make them individualized for the communities in which we live in. One of the ones that I really, really like, and I've presented some of these, and if you're interested in these, you can email me at ebony.fisher@joyce.edu. I can send you some of these tools that you can utilize in your areas, and to be able to determine who has healthcare disparities in your communities. But one of the ones that I really like is the Everyone Project. It promotes diversity and addresses the social determinants of health and to advance health equity in all communities. It's a toolkit, and it includes little strategies out there to help us to improve the areas in which we live and to help our patients and help them to thrive in the which they are in. And, you know, some of us can't change the communities that we're in, but however, we can make the communities that we are better. And so I think that is an excellent one. So again, if you're interested in those tools, there are hundreds of tools out there that determine the different types of social determinants out there that our clients can have. And I am more than happy to share those with you. So diagnosis, we need to be able to also integrate assessment information that we get from those assessment tools into our workflow. Okay, so how do we do that? So we can do those by introducing new care models that prioritize the efficient use of information that we get through electronic health records. And that lets us be able to develop tools that would help those populations that we determine are at risk for social determinants of health and those healthcare disparities. So again, we need to learn more about our organizational policies and procedures for social determinants of health. What is your organization doing when it comes to combating the social determinants of health? If you don't know, you need to go find out and become familiarized with it. If they're not doing anything, we need to implore that your organization does something. Again, we can explore the EHR, the electronic health record, when it comes to documentation and to identify what social determinants data are. Maybe it's going to be age, race, income, all those types of things. Those will be flagged in the electronic health record, and that would cue to the nurse that those people are at risk for healthcare disparities. Also, we need to encourage our colleagues to have discussion with patients to understand their comfort levels with sharing their social determinants of health. I always have those conversations. I let my patients say whatever, you know, I listen. I don't try to interrupt them when they're talking. I let them say things, even if they are outlandish. I want them to be able to share, like, you know, how they actually feel. That's how I learned about COVID-19 and, you know, the government actually having a plot to get rid of certain races. We need to also support and advise organizational plans to implement the social determinants of health into nursing workflows. And we need to also look for opportunities to conduct nursing inquiries for social determinants of interventions, okay? And we also need to look at triage support based on individual responses. So if they respond to things that social determinant questions, then we need to be able to direct them to the appropriate multidisciplinary or interdisciplinary team member who will be able to help them, like nutritionalists, mental health professional, and those types of things. I believe those assessments can help us to greatly diagnose who is in need of our support. Also, we need to look at our outcomes and planning. So hospitals, clinics, public health agencies, we need to be able to work and to help to support those people who do have healthcare disparities and provide comprehensive care to every patient in every community, regardless of their ability to be able to pay. We need to look at ways in helping them to be able to pay. We need to be able to advocate with our fellow government in order to develop plans and policies and financial budgets that will help these people who do have healthcare disparities. Again, that is super important. And in the public health sector, needs to also declare racism as a threat to public health and look at those all-encompassing healthcare qualities that are experienced every day within our healthcare system. And then we need to also look at transportation. We need to look at housing and healthcare and look at what ways in which we can better those areas because it is a public health crisis when it comes to these healthcare disparities. And nursing education, we need to be, the research has shown that healthcare educations do not incorporate social care determinants into their curriculum like they should, okay? So we need to be able to design curriculums that better help our students to better understand the root cause of these healthcare disparities that are experienced out there. Why do we have social healthcare equities? Why do we have people who don't have social support? Why is this occurring? How can we better this? How can we help people regardless of their socio-economic status? How can we prevent racial biases and stereotyping when it comes to our health care professionals? Because that's going to affect the people in which we serve. And then our government needs to look at our policies. Are there policies out there that are focused on childhood education, child poverty? Are there any types of investment strategies that are going to help the poor? Do we have adequate housing? Do we have plans in order for us to establish good housing out here for our people who don't live in good housing, that do not have running water and electricity? Do we have, are we looking at our planned care like Medicare and Medicaid? Do those plans need to be upgraded? Social Security, does that need to be upgraded? Because again, those policies in place for those payer programs greatly affect healthcare outcomes. Implementation. Again, government, hospitals, public health agencies, and nursing educations need to be intentional about integration and implementation. Again, we need to be intentional about integration and implementation. We all can do it. It starts with the government, it starts with the hospitals, the public health agencies, and nursing education to make sure that we are implementing goals. We are looking at how we can better the social and problems that our communities face throughout the United States when it comes to health disparities and health inequities. And we can do it. We can do it. These all can be avoidable, but it can be done with education, policy change, and treating every patient as equal, and making sure that we do not have stereotypes and racial biases within the workplace. So now I'm going to open it up to and then I'm sorry, I forgot about evaluation. So again, we need to go back once we implement these goals and these ideals. We need to go back and evaluate. We need to look at research. We need to look at program evaluation, our curriculums, to make sure that our students are understanding what are the social determinants are, what our health inequities are. We need to review where our policies that we made, were they effective? If they're not effective, then we need to revise, we need to replan. And then like the Healthy People 2030, which they look at the data sets every decade, perhaps we need to look at them more frequently. Instead of doing it every decade, we need to do it every 2-3 years, every 5 years, because again, we can't let this go by without addressing what the concerns are. And then we need to look at evaluating and analyzing our healthcare outcomes and data for people who have low incomes, minority racial groups, and people who are in the Medicaid and Medicare recipients. Because again, those are going to be clues that there are inequities and healthcare disparities within our communities. Now I'm going to open it up for questions. If there are any questions, you can put it in the chat.
Okay, I have a question from Hafsa. Ebony. What is Healthy People 2030's perspective on community healthcare promoters addressing health disparities?
Again, they look at those 5 domains. We need to look at education. We need to look at access to healthcare. Those things that we just recently talked about. That's how they are looking at addressing those areas. So hopefully that gives you an aspect. So again, those 5 domains that we just discussed, that's how they are addressing them. And they are employing, agencies, hospitals, also to look at those 5 contexts of those domains and how they can implement them into their the government, the public sector, nursing education, across the board.
Does anyone else have any questions that they would like answered from Ebony? Okay, well, thank you, Professor Fisher, for that wonderful discussion on healthcare disparities. It is a very important aspect of all nursing care, especially here at Joyce. So thank you for all the information. And if anyone else has any last questions that they want to put in the chat, please do so now. And if not, thank you for coming to our community series today.